Now talk about the thorax. So talking about thorax, let's first see the sagittal section of the thorax. So we have the mediastinums here. This is the thoracic cage. This is a thoracic cavity, and this is called as the thoracic inlet, and this is the thoracic outlet formed by the diaphragm. And the thoracic inlet is formed by the Sibson's fascia. What is Sibson's fascia? We'll discuss. This is your Sibson's fascia. We'll discuss about this. It is also called the suprapleural membrane, remnant of scalenus minimus muscle. Scalenus minimus muscle. Understood? Let's talk about what are the things that are formed here. So we have the superior mediastinum, the space bound by the manubrium, the sternum, T1 to T4 vertebrae, and superiorly by a Sibson's fascia, and inferiorly by a sternal angle at the level of the sternal angle or angle of Lewis. We have this space which is the superior mediastinum, and this is your inferior mediastinum. Inferior mediastinum has three parts: your anterior mediastinum, your middle mediastinum, and your posterior mediastinum. Middle mediastinum, your heart lies, and this is all about your mediastinum. Let's talk about the Sibson's fascia. Mediastinum we'll discuss after completing all the structures of your thorax, as mediastinum is very important as per your long question is concerned. Mediastinum is often asked as a long question, or you can get a short note on, like, write a short note on your posterior mediastinum, write a short note on your anterior mediastinum. So you have to write all the structures, the boundaries, the contents, the extent, and all. Let's discuss the Sibson's fascia, that is the suprapleural membrane. So Sibson's fascia is attached to the transverse process of C7 vertebrae. From the transverse process of C7 vertebrae to the inner border of first rib, to the inner border of the first rib, like the rib and the costal cartilage, also to the junction between them. So it is attached from the transverse process of C7 to the inner border of the first rib. It is also called the suprapleural membrane. It is the remnant of your scalenus minimus muscle. And through the lung apex extends up to the root of neck. There is no puffing. There is no puffing of root of neck during respiration, as the lung apex reaches the root of the neck like this. But if the lungs is inflated, there must be a puffing of neck. The neck must puff out. Okay, like this. The neck must puff out, but the puffing is prevented by this fascia, which is called as the Sibson's fascia. Sibson's fascia gives rigidity to the thoracic inlet and prevents its ballooning in and out during your respiration. So that's all about the sagittal section in the Sibson's fascia. Let's move on to the next. Let's talk about your sternal angle, or which is called as the angle of Lewis. It is present at the lower border of T4 vertebrae, as you saw. This was the mediastinum somewhere like this, and in the lower border, we have the anterior mediastinum. This was the T4, which is called the angle of Lewis. This is the anterior mediastinum, and we had your this was superior mediastinum, and your anterior mediastinum, middle mediastinum, and posterior mediastinum here. So this is called the angle of Lewis. At the angle of Lewis, what are the important changes that are taking place at the angle of Lewis? So that is the origin and the end of the arch of aorta. The arch of aorta originates as well as ends at the angle of Lewis. Then as the division of trachea, practically the lower level of T5 in living subjects, or in cadaveric subjects, it is at the level of T4. So trachea divides at this point in living subjects in T4 level, and in cadaver it is dividing at T4 level, but practically we can have a little lower origin, that is T5. Division of the pulmonary trunk, point of attachment of second costal cartilage under the arch of aorta, left recurrent laryngeal nerve loops. There's a looping of the left recurrent laryngeal nerve, and there is the azygos vein drains into superior vena cava at the level of your angle of Lewis. Presence of cardiac plexus is there. Thoracic duct deviates to left at this level, and the junction of superior and inferior mediastinum is at this level. So that's all about the changes of angle of Lewis. Let's move on to the next. So let's talk about the diaphragm. Very important topic. Diaphragm is a very important topic. You have to remember the contents of the openings and all. So here's the structure of the diaphragm. Here's the crust of the diaphragm, the medial arcuate ligament, lateral arcuate ligaments, and all. We'll go to the discussion. We'll discuss this section when we'll discuss the schematic after discussing the schematic section. So in the superior part of this diaphragm, we have two foramens, that are the foramen of Morgagni, by which superior epigastric vessels are gonna pass. Then we have a central tendon of diaphragm. This is central tendon of diaphragm, which is a non-contractile structure. Then what we have your medial arcuate ligaments in this side, medial sides, medial arcuate ligament, which are the thickenings of a psoas major fascia, and if the lateral arcuate ligaments present, lateral arcuate ligaments are present in this side and in this side, where your thickening of your quadratus lumborum fascia is there. There is a thoracolumbar fascia. Thoracolumbar fascia forms a lateral arcuate ligament. We talked about this in your abdomen also. And then we have your right crus of diaphragm and the left crus of diaphragm. Right crus, which is a bit longer than the left crus of diaphragm. And we have the sympathetic chain that is running parallel to the right crus of diaphragm. And we have the splanchnic nerves that are arising from here, the splanchnic nerves, and the hemiazygos nerve that is arising from the left crus. So this was overall the gross structure of your diaphragm. And let's discuss the major openings. So you have an opening here labeled 1, opening here labeled 2, and opening between your left crus and right crus that is labeled 3. So you have 3 important openings in the diaphragm. So 1, 2 and 3. 1 is called as the voice. Okay, you can just remember voice of America to remember these openings. Voice of America, where 1 stand for your vena cava opening. 1 is the vena cava opening at the level of T8 level. At the T8 level, 1 is there, your vena cava opening, and O is the esophageal opening that is present at the T10 level. This one is called as the esophageal opening, or your hiatus, which is present at the T10 level, and 3 is the aortic opening, which is present at the T12 level. This is T12. So T8, T10 and the T12 levels. Okay, so that's about openings. Let's discuss the openings in detail. Talking about the vena cava opening, it is present in the central tendon, as you saw above. The contents are your inferior vena cava and the right phrenic nerve. You can well observe your heart here. This is the right phrenic nerve that is present, and this is your left phrenic nerve. And this right phrenic nerve along with the IVC, this there must be the vena cava opening of the diaphragm. If this is a diaphragm, there is a vena cava opening. This is the right phrenic nerve and the inferior vena cava coming out. Talking about esophageal opening, it is present in the right crus, which gives passageway to esophagus, right and left vagus nerve, and the esophageal branch of left gastric artery. So this one, it is this one is called as your esophageal opening. Understood? Then we have to talk about the aortic opening, which is present between the crus. So you have the aorta, thoracic duct, azygos vein, and hemiazygos vein. Optional content: hemiazygos vein, azygos vein. So these 3 are absolute, like aorta, thoracic duct and azygos vein. These 3 are coming out of your third opening. Third opening was your aortic opening, which is present between the crus. And the content of the foramen of Morgagni is the internal thoracic artery and veins. Internal thoracic artery and the veins. Talking about this, let's discuss the diagram. So you can see the first opening. You can see the second opening. Second opening is formed generally by the turn of your right crus. So it is we can tell that it is present in the right crus, but it is in the structure, in the schematic diagram, it is showing up like the right crus is turning like this, forming the second opening. So second opening, what are the contents of the second opening? You know, esophageal hiatus. What are the contents of your opening for in the vena cava opening, and what are the contents of the aortic opening? You know all this. So now let's move ahead. And okay, this right crus of diaphragm is supplied by both the right and the left phrenic nerves. This is an important fact. So that completes your diaphragm. About the openings we had to mainly study. Then afterwards, let's move on to the next part. Let's talk about the thoracic wall. So you have the intercostal spaces and the thoracic wall. So rib is attached twice to the vertebral column. If we talk just about the ribs, the basic introduction. One to the body, it is attached. The first articular surfaces is the body, and second it is attached to the costal facet of transverse process. Costal process of the transverse facet, and one to the body. What are the intercostal muscles? The external intercostal muscle, internal intercostal muscle, and the innermost intercostal muscle. There's a misprint in BDC, please note. This is the innermost intercostal muscle. BDC it is written your intercostalis intimae in place of your innermost intercostal muscle. So you don't but the main thing is the innermost intercostal muscle, which is present, external, internal, and the innermost. This innermost intercostal muscle has in turn 3 parts, that is your subcostalis, intercostalis intimae, and your sternocostalis. Sternocostalis also has the transverse thoracis. Neurovascular plane in thorax lies between the internal and the innermost intercostal muscles. So there is the there's a neurovascular plane, and there's the blood vessels are present between the internal and the innermost. So talking about that, this is the external, this is the internal, and this is the innermost. So you have the arrangement like vein, artery, and nerve. Okay, we have the arrangement like vein, artery, and nerve. Below the margin of the rib, vein, artery, and the nerve. And for intercostal nerve block, we are piercing this it should be done in the upper part, so as to prevent any damage. And this arrangement is constant, like vein, artery, nerve is constant, except in the first intercostal space where there is nerve, artery, and vein. And these are the main branches, and with the collateral branches also, small collateral branches which are arranged in nerve, artery, and vein. These are the collateral branches of the main vein structures. These are vein structures, so these are just collateral branches. So pleural tapping, if there is we have to do the pleural tapping, it must be done in the upper border of lower rib to prevent injury to vein, artery, or nerve. It should be done in upper border of lower rib. Here we have to do the pleural tapping. This is the site for your pleural tapping, so as to prevent any injury to these parts. And for intercostal nerve block, the needle should go from the lower border of upper rib. So as to do here intercostal nerve block, because here we have a intercostal nerve, artery, and the vein. Understood? And let's see the arrangement of external and internal intercostal muscles. So this arrangement is given well in your BDC, and if you just look at the fibers, how they're rising, this is your upper rib, this is your lower rib. So we have the innermost intercostal, which is present posteriorly like this. It must be covering the posterior part. You can appreciate in this 3D diagram. And the external intercostal muscles, these are coming from back to the front. Okay, these are coming from the back to the front, and this internal intercostal are going back. Okay, these were coming from the front and going to the back. And just note that this external intercostal and this internal intercostal muscles, these are mutually perpendicular to each other. Okay, you can see the arrangement here also. Your external intercostal muscles extend only up to the costochondral junction, and when it reaches the costochondral junction, it becomes an external intercostal membrane, not the muscle. So this is the arrangement of your external intercostal membrane. We will see in the transverse section. Let's take a transverse section of this part. So here is our vertebrae, and here's the sternum, and it's the anterior side, this is the posterior side, this is the lateral side, this is the medial side. So what we have, first we have external intercostal muscle. External intercostal muscle, when it reaches the costochondral junction, it becomes the external intercostal membrane. And your innermost intercostal muscle, this is innermost intercostal muscle. There is the innermost intercostal membrane which is attaching the innermost intercostal muscle to the vertebrae, and then have the muscle that is your this is your innermost intercostal. Just pardon me. This is the internal intercostal. This is your innermost intercostal muscle. So you have three parts: subcostalis, intercostalis intimae, and your sternocostalis. So these three parts are basically making up your innermost intercostal muscle. That's all. If you do from pleural tapping, we're talking about the pleural tapping from anterior side. What are the structures that are pierced? So you have about 8 structures which are pierced. First is your skin, that will be pierced. Then we have the fascia, that is pierced. Then third one is the serratus anterior muscle, that is pierced in pleural tapping. Then we have the external intercostal muscle, your internal intercostal muscle, your innermost intercostal muscle, that is your intercostalis, and your endothoracic fascia, and the parietal pleura of the lungs, which is pierced in the pleural tapping. This is the whole structure, this is the whole arrangement. You can see this is a lung, the lung tissue is starting from here. We are taking cross section, just a section from this. And talking about intercostal nerves, so we have the typical intercostal nerves which only supply the intercostal space. And other ones are supplying, just giving branches to any other things, also are contributing to other things. Like your T1, we are going from T1 to T12, all the nerves, we are discussing all the nerves, and then we will see what are the typical intercostal nerves. So this all are not typical. We have atypical ones also, like the T1, it is contributing to the brachial plexus, so it is atypical. We know that T1 is contributing in the brachial plexus. T2 is caused the intercostal brachial nerve, so it is also not typical. T3, T4, T5, T6, these are the typical intercostal nerves. So we have about 4 typical intercostal nerves, okay, and sometimes we exclude this 3 also, so there are 3 typical intercostal nerves, this statement is also correct, and there are 4 typical intercostal nerves, this statement is also correct. Most correct is your 4. And this T7, T8, T9, T10 and T11 are your thoracoabdominal nerves which supply the rectus sheath, so these are not typical. And this T12 is called as a subcostal nerve, so this is also not typical. Let's talk about the course of a typical intercostal nerve and how a typical intercostal nerve is going. So this diagram is present in your books, and let's talk it in the schematic manner. Talking about the course, we have from the spinal cord, a typical intercostal nerve arises. This is the spinal cord, transverse section of the spinal cord from which it arises from this trunk part, and this here it is a little bit complex, so I am not going into details about the dorsal root ganglion and how it is connected to this part where the lateral branch and the dorsal ramus give rise to your typical intercostal nerve, and how the pleural branches are going. I am not going into detail. Let's talk in a very simplified manner as you can understand better. This is your external intercostal muscles, and this is the external intercostal membrane. This is your internal intercostal muscle membrane, and this is your internal intercostal muscle. This is your sternocostalis, intercostalis intimi, okay, and your transverse thoracis. So talking about these muscles, the typical intercostal nerve, the nerve goes beneath your innermost intercostal and your internal intercostal muscles. It goes like this, and at the level of when there is the presence of your external intercostal membrane, it pierces the IICM and the external intercostal membrane and divides into this branch and pierces. This is called as your anterior cutaneous branch. This anterior cutaneous branch divides into left branch, your left branch, and the your lateral branch and your medial branch, okay. And here at the level where there is the where the external intercostal muscle and the internal intercostal muscles are present, here is a lateral cutaneous branch. This lateral cutaneous branch divides into posterior branch and your anterior branch. This anterior branch and the lateral branch anastomose with each other. So lateral cutaneous branch pierces the IICM and the EICM muscles. Note that it is muscles, but your anterior cutaneous branch, it pierces the external intercostal membrane. It pierces the internal intercostal muscle, but not the external intercostal muscle. It pierces the external intercostal membrane. Understood? So this is all about your thoracic wall. Let's talk about the intercostal arteries. We are not gonna discuss this diagram. It is a little bit confusing. You can also discuss this diagram also. It is not much difficult as it seems. Here means thoracic aorta present. So this is the posterior intercostal arteries. In the posterior intercostal artery, it gives a collateral branch also, and this collateral branch and the posterior intercostal artery, this come and fuse it anastomose with the anterior intercostal arteries AICA, which are originated from the ITA, internal thoracic artery. And same thing will occur in this side here. So this is all about your arteries, intercostal arteries. Let's get into your schematic arrangement if you just want. So what we have done is that we have the ribs are present curved. The ribs are present curved, but what we have done is we have flattened the ribs. We have flattened the ribs and are seeing the rib from its inner side. So here must be the sternum. Here we have flattened the rib, so there will be costochondral junction here, and the rib will be present here. The rib is present here. This is upper lip. This is your lower rib, and from here there is an internal thoracic artery. The internal thoracic artery which will be giving AICA branches. What is AICA? AICA is your anterior intercostal arteries. And this aorta is giving a posterior intercostal artery and your collateral branch of posterior intercostal artery. So this posterior intercostal artery is fusing with one of the AICA, and this collateral branch is fusing with another AICA. So this you can say that posterior intercostal artery is fusing with the anterior intercostal arteries. Okay, the two anterior intercostal artery, one posterior intercostal artery, and one is the collateral branch of your posterior intercostal artery, and where they are fusing at the costochondral junction. Okay, so here is the important fact that the internal thoracic artery, it is important for bypass grafting. Why? Because it has EGSS, and histologically it acts as a large sized artery. It is not a large sized artery, but histologically it acts as a large sized artery, that is, it has high elasticity. So it is important for the bypass grafting. Let's talk about the internal thoracic artery and how is the course of the internal thoracic artery and how it is dividing into the musculophrenic and the superior epigastric arteries. Let's see. This is the first part of a subclavian artery. Okay, we saw here the arrangement, AICA, two AICAs are originating. So that will occur in every rib, right? That will occur in this rib and between these ribs and all. So every rib there will be AICAs. So how it is given? First part of subclavian is there. First part of subclavian will give rise to internal thoracic artery. This will come down beneath the ribs and will give two branches of anterior intercostal arteries, two branches of anterior intercostal arteries, and there are two terminal branches at the level of a sixth intercostal space. This internal thoracic artery, this divides into your musculophrenic artery and your superior epigastric artery. This musculophrenic artery will give anterior intercostal arteries in the 7th to 9th intercostal spaces, and this anterior intercostal arteries directly from the internal thoracic are supplying up to 1 to 6 intercostal spaces. This is the first, this 2, 3, 4, 5, 6, but from the 7th to 9th intercostal space, the branches of anterior AICA branches are given by your musculophrenic artery, which is a terminal artery of an internal thoracic artery. Understood? After that, we have a superior epigastric artery, which goes via the foramen of Morgagni. Remember, we talked about it in diaphragm, the foramen of Morgagni, two foramens, and becomes the content of your rectus sheath. So, what are the branches of your internal thoracic artery? You have the superior epigastric artery, this one, and your musculophrenic artery, this one. Musculophrenic artery was this one, and these two are terminal branches, as I told earlier. Then anterior intercostal arteries in the 1st to 6th intercostal spaces, these are anterior intercostal arteries, and your mediastinal branch is there, which is which supply the remains of the thymus. Okay, the thymus gland remains, and the pericardiophrenic artery, which runs with the phrenic nerve and supplies the diaphragm, mediastinal pleura, and fibrous pericardium. So these branches are not shown here. You have the mediastinal branch and the pericardiophrenic artery. In females, you have a perforating mammary branch, perforating mammary branches in the 2nd to 4th intercostal spaces to supply the breast. Remember, we told this perforating branches of ITA in breast. You can check the upper limb lectures. Let's discuss the venous drainage. The arrangement is a little bit complex, I can say, but once you have understood, you can you have to just practice this diagram as many times as you can, so as to retain the concepts. So this is the azygos vein and the hemiazygos vein, and how they are draining into your inferior vena cava and into your superior vena cava. This is all about them, and then we'll talk some clinicals and finish off your many clinicals are there, okay, which are not given it is given in one book, absent in another. So what I have done is I have used some books from for your thorax, like your Gray's 42nd Gray's, and your another book which is Visram Singh's Clinical and Surgical Anatomy, and another book is a self-assessment review by Rajesh Kausal. So I have used these books and made this notes from there. So let's discuss from these notes, so it will be easy for us to retain and review. Let's talk about the venous drainage. So azygos vein drains into superior vena cava at T4 level. This is a fact. Let's discuss how it is running. So first of all, you have a superior vena cava here, let us go in retrograde manner as a vein goes. Let's go in the retrograde manner. So talking about the retrograde manner in which the veins are going. Okay, let's discuss from the right first intercostal vein. From the right first intercostal space, your right first intercostal vein is coming, which is draining into your right brachiocephalic vein. Okay, and this right brachiocephalic vein is going and converging into a superior vena cava. And the left side we have our left first intercostal vein, which is draining from the left side of the that part, intercostal, the first intercostal space of the left side. It is drained by left first intercostal vein, which is draining into brachiocephalic vein, left brachiocephalic vein. As this right one draining to right brachiocephalic, this left is draining to left brachiocephalic, and this is again converging into your SVC. Then we have another arrangement, that is, this is called the right lumbar ascending vein. Just look at this. This is called the right lumbar ascending vein. At the level of this, we call it as right lumbar azygos vein. This azygos vein is running like this, and it's draining into superior vena cava. This is the azygos vein, the continuation of your right lumbar ascending vein. So azygos vein is basically a continuation of your right lumbar ascending vein. This is the azygos vein, and this azygos vein is particularly in the azygos vein, your blood from the second, third, and the fourth intercostal space are draining. So we have the right second intercostal vein, right third intercostal vein, which are draining into the fourth. It is draining into the fourth, and the fourth is draining into your at the level of T4. It is draining into your azygos vein. So azygos vein drains into SVC at the T4 level, at which these veins are draining. Then we can have this arrangement from this fifth intercostal space, 6, 7, and 8. So the right fifth intercostal vein, right sixth intercostal vein, and all, which are draining directly into your azygos vein. Okay, and in this right brachios, in this left side, let's come to the left side. So in the left side, this second, third, this both this type of arrangement as in the right side. So second and third intercostal veins, that is the second, left, third intercostal veins, are draining into fourth, and fourth is draining again into your left brachiocephalic vein. Talking about accessory azygos vein, accessory hemiazygos vein. Talking about an accessory hemiazygos vein, this accessory hemiazygos vein drains into your azygos vein. How? It takes the blood from your fifth, it contains your fifth left intercostal vein, your sixth left intercostal vein, seventh and eighth, and from here this all are draining into your accessory hemiazygos vein, and this accessory hemiazygos vein is now merging with your azygos vein. Then we have another hemiazygos vein. So let's talk about the hemiazygos vein. So what happens in the right side, we have the draining of your 9, 10, and 11, the limb from your 9, 10, and 11 in the right subcostal vein. Also your 12th one is the right subcostal vein, which are draining into your azygos vein. Okay, and this is connecting to the inferior vena cava by right lumbar azygos vein. And then we have our from the in the left side we have our 9, 10th, 11th, and the left subcostal vein, which are draining into hemiazygos vein. So draining into hemiazygos vein, and this hemiazygos vein is again draining into your azygos vein. So if you understood this branch from here, it is called as your right superior intercostal vein. And we have another part, this one is called as your this one is called as your left superior intercostal vein. So these are your intercostal veins. Right superior intercostal vein, these are special names only, and left superior intercostal vein. This is the whole arrangement. So how is the azygos vein formed? It is formed by the right subcostal vein, that is this one. You can see your right subcostal vein is contributing to it, and your right lumbar ascending vein, and your right lumbar ascending azygos vein. So it is forming like this: right subcostal, right lumbar ascending, and your lumbar azygos. So it is forming at this level. This is your azygos vein. This one. So if you understood how the azygos vein is formed, let's move ahead and discuss the clinical. So you understood the venous drainage and how the azygos vein and hemiazygos veins are going. Let's discuss the clinical. So upper and lower two ribs are the least common injured ribs in crushing injury of the chest. Why? Because these upper two ribs are protected by the clavicle, and lower two are floating ribs. Understood? Fractured ribs are very painful because the fractured parts move during respiration, coughing, and sneezing. Understood? Ribs of infants and children usually don't fracture in crushing injuries because the children, the infants, they have mainly cartilages. The ossification hasn't completely occurred, so they have recoiling property in their ribs, so they don't usually fracture using the crushing injuries of the chest. But if there is heavy crushing, then they can also fracture of ribs. It occurs commonly in older people as compared to younger people because there is more calcification in older people. Frail chest. What is the frail chest? It occurs in severe crush injuries where a part of your ribs, like 1, 2, 3 ribs, have broken down, and this is forming a separate segment. And this segment moves during your inspiration, and this segment moves during your inspiration and expiration. So this flail segment is sucked in and out during the respiration, which is called as a paradoxical respiration. So what is paradoxical respiration? It occurs due to your flail chest. Then a funnel chest, that is called the pectus excavatum. This is a developmental defect in which the chest is compressed anterior-posteriorly. This chest is compressed anterior-posteriorly. This is called as a funnel chest. In severe cases, it may cause compression of the heart. Then we have the pigeon chest. Pigeon chest is called the pectus carinatum, in which the chest is compressed from side to side. So pigeon chest, the chest is compressed from side to side, not in the anterior posterior. Anterior posterior compression is called the pectus excavatum, and pectus carinatum is the chest compression from side to side. What are the causes? Chronic respiratory disease in children and rickets. And the Harrison's sulci are seen in the pigeon's chest. Talking about sternum. Sternum is the preferred site of bone marrow aspiration, while the reason is the subcutaneous and it is easily accessible. You can easily palpate your sternum. And sternal puncture is not advised in children as it can cause a mediastinal injury. The sites of bone marrow aspiration in children are the upper end of tibia and the iliac crest. Respiration in the first 2 years of life is entirely abdominal. The most in thorax at the birth after 2 years, there is a constant surface area, but in adult thorax the diameter increases due to thoracic breathing. So in respiration, first 2 years is entirely abdominal respiration. Most commonly separated rib is the 10th rib. First prominent tuberculous vertebrae that points on the surface of thoracic wall following 3 sides. You can just correlate with the typical course of an intercostal nerve. Not the nerve. You have to correlate with this diagram, which has all the muscles. Okay, all the muscles showing the muscles of a thoracic wall. So those can be formed here, lateral to the erector spinae muscle, or it can form here in the mid axillary line, or it can form here at the just lateral to your sternum. Infants are susceptible to pneumonia after abdominal operations because in abdominal operation the infant resists the breathing due to pain, and there will be accumulation of secretions in the lungs, and lungs will become affected and cause pneumonia. So that completes the thoracic wall. Let's move on to the next. So now let's talk about our heart. It is a very important concept and a very important topic. It is very interesting to learn about the heart. Let's talk about the pericardium, that is the covering of the heart. We have a fibrous pericardium and a serous pericardium. Serous pericardium is divided into parietal pericardium and the visceral pericardium. Visceral pericardium is also called as the epicardium. So you can see here is our fibrous pericardium. And we have our parietal layer and the visceral layer that is forming the serous pericardium. So we have a fibrous pericardium and a serous pericardium. So this is your serous pericardium, which contains a parietal layer as well as a visceral layer. This visceral layer is intrinsically connected to your heart. And here we have a tendon which is called as a central tendon. This is the base of the heart and this is the apex of the heart. Apex of the heart is merged with the tunica adventitia of great vessels. And this base of the heart is broad and this apex is very tapering and narrow. Talking about this pericardial sinuses, we have a transverse sinus and an oblique sinus. So we have two pericardial sinuses also. Like this one. Consider this one. This is your oblique sinus. And this pericardial sinus is the transverse sinus. This yellow one you can see is a transverse sinus. If you take a cross section, we have a right atrium here. Let me label and show you. This is our right atrium, and your pulmonary trunk ascending aorta is present here, and the left atrium is present here. Then left auricle you can say, or left atrium. Left auricle is there, and the left atrium present here. Left atrium is present over here, and the right atrium and left atrium you can see. Your right ventricle is not visible, it's present posteriorly, and this is the oblique sinus of the pericardium. There is the oblique sinus of the pericardium, but we have the transverse, this is the transverse sinus, and this is the oblique sinus, that's the oblique sinus of the pericardium. The transverse sinus and your oblique sinus. If you just understood the structure, this what is the use that oblique sinus, it allows the left atrium to expand without compressing the esophagus. Without compressing the esophagus, the left atrium can expand. Okay, so sinus means a space, so it is providing a space to expand, to produce your expansion of the left atrium to, so as to prevent the compression to the esophagus. So here is our schematic structure. Of course, we discuss in schematic structures because it is very easy to draw even and reproduce. So here we have the structure of the heart. Here is our artery. This is called as the arterial tube. This is called the arterial tube. Here is the ascending aorta, and here is the pulmonary trunk. Ascending aorta and the pulmonary trunk. And here is our transverse sinus. Here is the transverse sinus, which is present behind the ascending aorta and the pulmonary trunk. Present behind the ascending aorta and pulmonary trunk. And using this sinus, the surgical ligature of your ascending aorta and pulmonary trunk, the surgical ligature, it can be tied using this sinus. Then we have a superior vena cava and the inferior vena cava, and this coverings are there, and this sinus is formed behind your left atrium and your pulmonary veins. Behind the left atrium and the pulmonary veins, you have an oblique sinus present over here. These are your superior vena cava and inferior vena cava, and these are your 4 pulmonary veins, and this is the oblique sinus. This is your oblique sinus, and this oblique sinus is allowing the expansion of your left atrium without compressing your esophagus. Let's talk about the heart, the base and the apex and all. So this is the superior vena cava of the heart, and this is the right atrium. This is right atrium of the heart. This is the right ventricle of the heart, and this is your left ventricle of the heart. So your left atrium must be situated in that side. Okay, so as seeing the heart in this manner, and this is your left auricle. This is your left auricle. Left auricle is only seen. The left atrium is not seen here, as will be present more posteriorly. This border is called the left border. Let's take some other colors just to prevent any confusion. This is the left border of heart. This is the left border of heart, and this is the right border of heart. Right border, more vertical is there. This is the apex of the heart. Apex of the heart is present in the left 5th intercostal space, just lateral. Sorry for the noises, as some neighbors are there. So this is the right border and the left border and the inferior border. This is the inferior border, and the apex of the heart is present in the left 5th intercostal space, just lateral to a mid clavicular line. And this is just gross structure of the heart. This base is formed by left atrium. 2/3 of the base is formed by the left atrium, and 1/3 is formed by your right atrium. This is the base, and this is the apex. Let's discuss about the surfaces. We have the anterior surface, which is called as the sternocostal surface. Inferior surface is the diaphragmatic surface, and the left lateral surface. 3 surfaces: anterior, inferior, and the left lateral. You can see your surfaces. It is not visible here. Okay. Let's discuss the right atrium. It has a rough anterior wall and a smooth posterior wall. So what we have done here is that we have removed, to expose the right atrium, we have removed the flaps, which is called the musculus pectinati, the muscles which were covering the right atrium. We have removed these muscles, and now we are into your right atrium. Now we are seeing the right atrium. So if we see the right atrium, we will observe the presence of your superior vena cava opening and the inferior vena cava that is opening here, and then we'll have our AV node. AV node is present in this part, and there is a triangle. There is a triangle here, which is the pink triangle, is called the triangle of Koch. We'll discuss about that, which contains your AV node. And this is a flap, which is the tendon of your Todero. Tendon of Todero is there. This is the right auricle. Auricle is generally like a flap of a dog's ear. Okay, auricle is like a flap of a dog's ear, or so it's just a pouch-like thing. It is not your right atrium and your right auricle. These are not synonymous terms, as said by some teachers. And this is the fossa ovalis. And here we have the limbus of the fossa ovalis. Then we have a septal cusp here, and the AV node is present over here, and the opening of coronary sinus is just at the edge of this triangle of Koch. And this part is called as the crista terminalis. This diagram will also discuss in your embryology part, so it is important. And this is the reflected anterior wall. Understood? So let's move on to the real time section. So in this real time picture, you can see you have a superior vena cava here, and in the arch of aorta, these three branches of the arch of aorta, we know this is your SA node, and we have removed the arterial flap, we have removed the pectinate muscles, the musculi pectinati, which is called, and this is a terminal crest. So on removing this flap, this is the anterior wall which is reflected upon. On removing this flap, you will see your fossa ovalis. You will see the triangle that is called the triangle of Koch. This is the triangle of Koch in which AV node is present. Triangle of Koch, which contains your AV node. Then we have the eustachian valve of inferior vena cava. This inferior vena cava opens in the valve which is called the eustachian valve. Then we have the Thebatian valve. This is a Thebatian valve, which is the valve of your coronary sinus. The coronary sinus opens into the Thebatian valve. Okay, and your superior SA node, the opening of the SA node is there. This you can correlate. After let's discuss the right ventricle. So we'll talk about the structure also, but let's first discuss the schematic diagram. So right ventricle, it has a rough inflowing part and a smooth outflowing part, which is called as the infundibulum. So this you can see, it is the infundibulum. It's the smooth outflowing part of your left ventricle, and this is the rough inflowing part. This is the outflowing part, and this is the rough inflowing part. Rough part because it is comprising of a trabeculae carni. This trabeculae carni muscle is arranged in form of ridges are there, bridges are there, and pillars are there. So this pillars are called as the papillary muscles. So papillary muscles are nothing but they are a form of your they're a form of your trabeculae carni itself. We have the septal cusp here, supraventricular crest, and all the trabeculae carni. This is called as your papillary muscle. This is the anterior papillary muscle, okay, which is the largest papillary muscle. It's the anterior papillary muscle, to which this caudate tendineae is attaching. Caudate tendineae, these are preventing the backflow of blood by holding to the cusps and connecting the papillary muscles to the cusp of the valves. Why it is going? Yes. Then we have the septomarginal trabeculae. This is the septomarginal trabeculae. It's a moderator band, acts as a moderator band, which gives passageway to right bundle branch and the bundle of His. You know about the right bundle branch and the bundle of His, yes, because these are specifically your conductive system of heart. Heart has an intrinsic conductive system, like impulse are conducted from the SA node via the thorax bundle, your Van Quebec's bundle, the Bachmann's bundle into your AV node. Then from AV node it goes via your bundle of His and divides into right bundle branch and the left bundle branch, which goes to the right ventricle and the left ventricle respectively. And after this they divide into different fibers, which are called as the Purkinje fibers. So this is a conductive system of heart. So this is a moderator band which is allowing passageway to the right bundle branch of and the bundle of His. So passageway to the right bundle branch of the bundle of His. Then the papillary muscles, we have anterior papillary muscles, which are largest, posterior papillary, and the septal papillary muscles also. So we have the three parts of papillary muscles. We have 8 sets of papillary muscles in our heart. Let's discuss the coronary circulation. You have read your coronary circulation in a physiology also. So you can see we have the right coronary artery, and the left coronary artery, which is arising. So this ascending aorta, we are talking the ascending aorta. This is a transverse section of the ascending aorta. So from 1, 2, and 3, these are your aortic sinuses. So first aortic sinus here, this is the anterior aortic sinus, anterior side, and this is the posterior side. You can say this is the posterior side, this whole part, and this one is the left side. Okay, left posterior and right posterior, right posterior and the left posterior. So talking about this, we have the first one, that is the anterior aortic sinus. Then second one is the right posterior aortic sinus. This one is the right posterior aortic sinus. This third one is the left posterior aortic sinus. This third one is the left posterior aortic sinus. From the left posterior aortic sinus, that's from 3, the left coronary artery is arising, left coronary artery, And sometimes left coronary artery also can arise from the anterior aortic sinus. From the first part, that is your anterior aortic sinus, your right coronary artery is arising, and this second one is called as a non-coronary aortic sinus, which produces a bulge in the interarterial septum, and this bulge is called the torus aorticus. So this is a bulge in the interarterial septum. This is called as the torus aorticus. We have in diagram or not? Let me check if we have this in diagram. Torus aorticus. No, we don't have the diagram for that. No matter, doesn't matter. We are focusing on the things, not on the diagrams. So here, what are the arrangement of this aortic arteries? Your coronary arteries. So talking about this, we have the RCA is the right coronary artery, LCA is the left coronary artery, PIVA is the posterior interventricular artery, and AIVA is the anterior interventricular artery. So let's talk about your arteries. Let's talk. So first of all, this part is the anterior aorta. This is the anterior aorta, and the left coronary artery is arising like this. It is giving a branch which is called the circumflex artery. So circumflex artery, it turns like this. It turns like this posteriorly. It turns like this posteriorly. Understood? And this circumflex artery also gives a branch which is called as your diagonal branch, which is called as the left marginal artery. Sorry, it's called as your left marginal artery or your obtuse artery. So what we have? You have a AA, that is your ascending aorta. Left coronary artery, which gives a branch, that is circumflex artery, which turns backward, which goes backward like this, and this gives a branch which is called as your left marginal branch, that is your obtuse artery. So this is the course of your left that artery. And another branch is coming like this, which is called as your AIVA. AIVA is the anterior interventricular arteries. This is the anterior interventricular artery, AIVA. This AIVA is coming to the front. It is present in the front, and the circumflex artery is going back. So this is the course of your LCA. So this orange one, and just remember that the anterior in the left anterior descending artery, that is AIVA. This AIVA, just note that it is also called as a left anterior descending artery. As it is present in the left anterior, as it is coming in front, and it is descending also. It is called as the left anterior descending artery, LAD. So if you see LAD somewhere, don't get confused. It's most commonly clinical terminology, we write LAD or say LAD. And this AIVA or your LAD, this gives another branch which is called as the diagonal branches. It can have one branch or multiple branches. Talking about the another branch, that is your RCA, right coronary artery. This right coronary artery, it goes backside and fuses with your circumflex artery. Fuses the circumflex artery of the left coronary artery. Understood? And this right coronary artery also has a branch which is given in the posterior side, and it is called the PIVA. What is PIVA? It is a posterior interventricular artery. And this PIVA fuses with the AIVA. This PIVA is fusing with the AIVA. Very simple. And another branch of PIVA, is supplying your AV node. And then you have another branch of your right coronary artery, which is given in front, which is called as a right marginal artery or an acute artery. Remember, we have left marginal artery, obtuse artery, which is a branch of your circumflex artery, which in turn is a branch of your left coronary artery, and your right marginal artery, which is called as an acute artery. This is a branch of your right coronary artery. And the first septal branch of your PIVA, first septal branch of your PIVA is supplying what I'm pointing. First septal branch of PIVA, this branch is supplying your AV node. Let's talk about the cardiac dominance. What is cardiac dominance? Let's talk about this. So in some people we have a right cardiac dominance. What is meaning? We'll talk in 90% of people, and in left cardiac dominance is there in about 10% of people. What is cardiac dominance? Is that the part of heart which is like stronger. Okay, which part will be surviving in a heart attack if heart attack occurs. So talking about your right cardiac dominance, if the PIVA is a branch of a right coronary artery, as we saw earlier here, this PIVA is a branch of a right coronary artery. Here we talked about the right cardiac dominance. This is your right cardiac dominance present in most of the individuals, but sometimes your PIVA is a branch of a circumflex artery. This is a PIVA which is a branch of a circumflex artery. This one, so just like you can imagine, this part is not present, and in the circumflex artery another branch is coming like this and supply and anastomosing with your AIVA. So this will be called as a left cardiac dominance, LCD I am writing. Understood what is left cardiac dominance? Yes. So this is your left cardiac dominance, and it is present in 10% of population. Right cardiac dominance is advantageous because in left coronary artery thrombosis, there is collateral circulation. Through this PIVA, and the chances of surviving a heart attack increases. Understood? You don't need to go in this diagram because it is like bit complex to understand. Okay, let's discuss something which is called as your this ascending aorta is there, and your LCA is there, right, left coronary artery, or RCA is there. Another branch of RCA is called as a right conus artery, and another branch of LCA is called as left conus artery. These are supplying the smooth part of your ventricular wall, that is annulus of Vicinus. Okay, annulus of Vicenus. Understood? Annulus of Vicenus is this part supplied by this right conus artery, and this right conus is the first branch of right coronary artery, is the right conus artery, supplying the smooth part, and this supplying the in this part, and forming a annulus of Vicenus. If right conus artery directly originates from the anterior aortic sinus, we call it the third coronary artery. If the right conus artery, this one, the right conus artery, it arises directly from the anterior aortic sinus. We talked about anterior aortic sinus. We had this type of arrangement. Yes. So this anterior aortic sinus, if it arises directly from the anterior aortic sinus, then we'll call it as the third coronary artery. So we have the left coronary, right coronary, and the third coronary. If it arises, not, it is very optional. Let's talk about the interventricular septum. So we have anterior two-third, which is supplied, anterior two-third of interventricular septum is supplied by the AIVA, that is your anterior in that interventricular artery, and posterior one-third is supplied by your PIVA, that is posterior interventricular artery. Let's discuss about the conduction system. This is the SA node, this is the AV node. We have three fibers. Here, anterior fibers, middle fibers, and the posterior fibers. And this is the bundle of His. This divides into right bundle branch and the left bundle branch, and again divides into your Purkinje branches. This both divide into Purkinje branches. So what are the innervations? So the right coronary artery supplies your SA node, supplies your AV node, supplies your bundle of His, and half of the left branch is supplied by the bundle right carotid artery. The right coronary artery supplies your SA node, AV node, your bundle of His, and half of your left bundle branch. So his left bundle branch is mainly acquiring its supply, half from your LCA and half from the RCA. And your left coronary artery supplies the right bundle branch and the half of the left bundle branch. Talking about the venous drainage, you have the coronary sinus for the venous drainage, the remnant of your lateral horn of your sinus venosus. Okay, and it is 3 cm long. Coronary sinus is 3 cm long and present in the posterior atrioventricular groove. So this is a coronary sinus to which all the veins are draining, and it's the remnant of lateral horn of your sinus venosus. So let's see what veins are draining into this coronary sinus. So first of all, we have our anterior cardiac veins which are draining like coming like this and piercing the part. And we have a vein of Marshall, that is an oblique vein of left atrium, and vein of Marshall, which is lying posteriorly and is draining to the coronary sinus. Then we have the great cardiac vein. There is a vein like going like this. This is called the great cardiac vein. This great cardiac vein is accompanying the arteries like a LAD and the circumflex artery. This is a great cardiac vein which is draining the coronary sinus. Posterior vein of left ventricle is also draining in the left sinus, coronary sinus. And then we have the middle cardiac vein, which is draining into your coronary sinus. This accompanies your PIVA, that is a posterior interventricular artery. And the small cardiac vein is coming like this and draining into your coronary sinus. The small cardiac vein has the RCA and the right marginal artery accompanying them. Let's talk about the nerve supply of the heart. So we are discussing the sympathetic chain, right sympathetic chain, the left sympathetic chain. So this is the sympathetic chain, and how it is forming a plexus or network, you can see here. First, let's discuss the short forms so that you won't get confused here, because there are a lot of short forms used. SCG is the superior cervical ganglion, middle cervical ganglion, inferior cervical ganglion. SCCB is the superior cervical cardiac branch, ICCB is the inferior cervical cardiac branch. SCP is the superficial cardiac plexus, DCP is the deep cardiac plexus. So how first we'll discuss how the SCP is formed, that is a superficial cardiac plexus. So first of all, we have our this right vagus nerve and the left vagus nerve. So we have right vagus and the left vagus. This left vagus nerve is giving your SCCB, that is your superior cervical cardiac branch, just forming your it's contributing to the DCP, that is a deep cardiac plexus, and is also giving us SCP. What is SCP? SCP is the superficial cardiac plexus. So it is contributed by only the left vagus and your superior cervical ganglion. Left vagus and your superior cervical ganglion, these two are only present in the SCP. And what are the components of your DCP, your deep that is your deep cardiac plexus? So the superficial cardiac and the cervical ganglion is contributing. Your middle cervical ganglion, your inferior cervical ganglion, T1, T2, T3, T4, T5, these all are contributing to the DCP. And from the right vagus, we have our SCCB, that is a superficial cervical cardiac branch, and the inferior cervical cardiac branch, that are also contributing to the DCP, that is a deep cardiac plexus. And another one is your RLN, recurrent laryngeal nerve, which is also contributing to it. So the recurrent laryngeal nerve is contributing, your SCCB and ICCB are contributing. Understood? And this ICCB and the your superior cervical ganglion is contributing to your SCP, that is your superficial cardiac plexus. And your middle cervical ganglion, inferior cervical ganglion, T1, T2, T3, T4, T5, and your recurrent laryngeal nerve, and another one is your SCCB. These all are contributing to the deep cardiac plexus. This is the nerve supply of heart. This SCP and DCP are mainly supplying the heart. So SCP, sympathetic, is the that is superior cervical ganglion of left sympathetic chain, and parasympathetic is the inferior cervical cardiac branch of your left vagus nerve. Inferior cervical cardiac branch, ICCP of your left 10th. Understood? So SCP, what is the components of SCP, you can see here. If you are getting confused, let me label this all. This is your SCCB again of vagus nerve. This is your ICCB, which is contributing to this superficial cardiac plexus, and this is your recurrent laryngeal nerve, RLN, recurrent laryngeal nerve. So SCP, so this SCP, this is formed by the recurrent, that is your ICCB plus the superior cervical ganglion. This both things are there in your SCB, that is your superficial cardiac plexus, SCB. Understood? Talking about the relations of a descending aorta, let's move on to the relations of the descending aorta. So we have our aorta is arranged like this, like we have anterior relation of the descending aorta. This is a descending aorta which is present, descending aorta. What are the anterior relations of the descending aorta? So we have a lung present somewhere like this. This is called as the root of the lung. We are seeing at the visceral surface of the lung, and heart and fibrous pericardium, then the lower part of the esophagus, diaphragm, and the descending aorta, which are forming your anterior relations of the descending aorta. And what happens is the aorta is divided into two parts, that is thoracic aorta and abdominal aorta. So this thoracic aorta is up to T4 to T12 level, and abdominal is T12 to L4 level. At the L4 level, it divides into your right common iliac artery and the left common iliac artery. This again divides into your external iliac, internal iliac, external iliac, internal iliac. Understood? Let's discuss the posterior relations of the descending aorta. If you want to discuss the posterior relation, so have the, of course, the vertebral column will be there, your azygos vein will be there, sorry, hemiazygos vein will be there, not your azygos vein. You can see this is the aorta, this is a descending aorta, and this hemiazygos vein is present in this posterior relation, and the accessory hemiazygos vein is also present in the posterior relation. In the right relations, we have our azygos vein. Azygos vein is present in the right, and we have a thoracic duct. This is your thoracic duct. This let me take some other color. This one is the thoracic duct. We will discuss the thoracic duct in this chapter also. Left relations, we have the left lung and the pleura. Understood? So in the left relations of the left lung and the pleura. So you know all these things. You know about the ascending aorta, arch of aorta, descending aorta. As arch of aorta gives three branches, that is your left subclavian artery, left common carotid artery, and the brachiocephalic artery. This brachiocephalic artery divides into a right common carotid artery and the right subclavian artery. So this is your descending aorta. What are the branches by the descending aorta? So first of all, you have two left bronchial artery which are gonna supply the bronchi, principal bronchus of the left. This is left principal bronchus, and is supplied by the two left bronchial artery. Then we have some esophageal branches supplying the esophagus, and there are 3 to 11 posterior intercostal arteries, and the 12th one is called as your subcostal artery. We have pericardial branches, supplying the pericardium, the heart, and in the terminal part we have two superior phrenic artery which are going to supply the diaphragm, superior phrenic artery. Let's talk about the coarctation of aorta. What is coarctation of aorta? Is that if the normal direction, the normal flow of blood is like this. Normal flow of blood in the posterior intercostal artery is like this, and from the anterior intercostal artery is flowing like this. Okay, this is the normal flow, which I have shown in blue, and there is the anastomosis. If there is abnormal flow of blood, like in this manner, if the blood flows in this manner, the blood pressure will increase, and this will lead to this coarctation, the narrowing down of the aorta, and this is called the coarctated aorta, and this coarctated aorta will cause, this will increase the tortuosity, due to increased blood flow, and this will cause rib notching will occur. Okay, rib notching means the border of the ribs will be abnormal. The border of the ribs will become abnormal, like these are abnormal shape of ribs, which are called as rib notching, and it is due to tortuous nature of your posterior intercostal artery. Let's talk about the pericardium. Pericardium has a fibrous pericardium and the serous pericardium. So serous pericardium has a parietal pericardium and the visceral pericardium, which is called as the epicardium. Let's talk about the blood supply and the nerve supply. So fibrous and parietal pericardium, the blood supply is from the internal thoracic, descending thoracic aorta, and musculophrenic artery, and nerve supply is your phrenic nerve, that is sensitive to pain. So the fibrous and the parietal pericardium is sensitive to pain. Talking about the visceral pleura, that is the epicardium. This is not pleura, this is pericardium. What I have wrote. This is not visceral pleura, this is a visceral pericardium, which is also called as an epicardium. And this epicardium, it is blood supply is your RCA and your LCA, that is your right coronary artery and the left coronary artery, and nerve supply is ANS. So it is insensitive to pain. So visceral pericardium or the epicardium is insensitive to pain. You know about all these branches, you know about how it divides. So superior vena cava divides into right brachiocephalic vein, the left brachiocephalic vein, and the arch of aorta has three branches: left subclavian, left common carotid, the brachiocephalic artery, and this is the ascending aorta. This is the arch of aorta, and the descending aorta continuing down here. The pulmonary trunk is there, dividing into two other branches. The right auricle is there, and there's ventricular parts and all. So this is the structure of heart. Let's discuss the ascending aorta. Ascending aorta is 5 cm long, and it is enclosed in the fibrous pericardium. So ascending aorta is enclosed in the fibrous pericardium, which is the outermost layer, the pericardial layer. So what are the things that this is your first costal cartilage, this is the second costal cartilage, this is the third costal cartilage. So at the level of third costal cartilage arises, the three dilatations are present, and these three dilatations are majorly your aortic sinuses. So we discussed the aortic sinuses few minutes ago, like anterior aortic sinus, right posterior aortic sinus, which is called as a non-coronary aortic sinus, and the left posterior aortic sinus. So it like goes like this, and this is a sternal angle at which the ascending aorta converts into an arch of aorta. We know the arch of aorta starts and ends at the sternal angle. Understood? So this is your ascending aorta, which is 5 cm long. What are the relations? Let's discuss. Anterior relations, of course you can see this must be a sternum. Anterior relation is the sternum. Here it is present. The sternum is lying in the back, so anterior relation is the sternum and the right auricle and the infundibulum of the right ventricle also. Posterior relation is the transverse sinus. Right relation is the SVC, that is superior vena cava. Right relation is the superior vena cava. You can see from here. Okay, right relation is the superior vena cava. Left relation is the pulmonary trunk. Understood? Let's talk about the arch of aorta. What is the arch of aorta? It is present in the superior mediastinum. It's the content of the superior mediastinum. Superior mediastinum you can appreciate like in that part which is bounded by the T4 and the sternal angle. Up to the sternal angle like this we had a mediastinum, right? So this type we had arrangement. This is a superior mediastinum in which the arch of aorta is present. And begins at the sternal angle. Like this at the T4 level. It goes upward, backward, towards left and downwards. Goes upward, backward, towards the left and downwards, like this. Then it ends at the left side of the lower border of T4. What are the relations? We have taken a transverse section, and we are seeing from inferior view. So what you will see is that you will see your arch of aorta like this, somewhere like this. Arch of aorta must be present, and your deep cardiac plexus must be seen in the front of your that is a trachea, and esophagus is there here, and left recurrent laryngeal nerve must be going into the plane of paper like this. Left recurrent laryngeal nerve, and you have a thoracic duct here which is present between the esophagus and the T4 vertebrae. Thoracic duct, and this is superior vena cava. And this all are forming an anterior relation. SVC, your deep cardiac plexus, your trachea, esophagus, left recurrent laryngeal nerve, and a thoracic duct. This all are forming a right and the posterior to the arch of aorta. They are forming a right and the posterior relation to the arch of aorta. They are present right and to the posterior relation. And what are the left and the anterior relations? So you can have your, first of all, you can have a left superior intercostal vein. Left superior intercostal vein is present like this. Your left phrenic nerve will be going like this. Your cardiac nerve, two cardiac nerves will be going like this, and your left vagus nerve will be lying here. This is your left and anterior relation of your arch of aorta. Talking about superior relations, what the superior relations are. So superior relations are a brachiocephalic artery, left common carotid artery, left subclavian, and the left brachiocephalic vein. So we have the in superior relation we have a brachiocephalic artery, left common carotid artery, left subclavian artery, and the left brachiocephalic vein. These are your superior relations of the arch of aorta. You can easily appreciate from this whole structure forming a superior relations. What are the inferior relations? You can easily write your pulmonary trunk, then your left ventricle, left auricle, all of them. So where I was there, yes. Inferior relation, the bifurcation of pulmonary trunk, you can write in the inferior relations. So that's the end of heart. Let's move on to the next part of this chapter. Let's talk about the lungs. So we have two important parts of this chapter, that is our heart. We have done with the heart, and let's talk about the lungs. I hope you understood heart very well. I've explained very slowly and showing all the things. Let's talk about the lungs. So let's come to the pleura. Pleura is the covering of the lung. We have the parietal pleura, which is the 4 types. The visceral pleura, which runs along the fissures of the lungs and forms the pulmonary septa, which divide the lung into your bronchopulmonary segments. So we'll talk about the bronchopulmonary segments later. So what are the parts of your parietal pleura? Just consider this diagram, and this white one which I am tracing is your parietal pleura. So in this upper region, this upper part, this which is marked 1, this is called as a cervical pleura. It's a neck region, so it is called as a cervical pleura. And the second part, this one is called as the costal pleura. This is your costal pleura. And the third part, this one is related to a diaphragm, so it is called as a diaphragmatic pleura. And the fourth part is related to a mediastinum, which is called as the mediastinal pleura. So we have a recess here. Two recesses are there. Here in the fourth part, we have a recess. It's called the costomediastinal recess. Costomediastinal recess, and it disappears during deep breathing. Disappears during deep breathing. And we have another recess, the costodiaphragmatic recess. It's important. Here we have the costodiaphragmatic recess, which is the most dependent recess. Okay, there is a fluid accumulation here in the pleura. There is pleuritis or pleural effusion. Pleuritis or the pleural effusion is occurring, then the fluid will be accumulated in this costodiaphragmatic recess. Is a recess of choice for the pleural tapping. Recess of choice for the pleural tapping. And pleural tapping, you just know that it's done in the 7th to 9th intercostal space in mid axillary line, and 8th intercostal space is the safest one. 8th intercostal space is the safest one. Let's talk about the bronchi. Bronchi, we have, you know about the trachea. Trachea bifurcates at the T4 level. We talk and cadavers in T4 level in your cadaver, and your living subjects, it may extend up to T5 or your T6 levels. Then we have the left bronchus, the right bronchus, left principal bronchus, the right principal bronchus. And this the division point is called as the carina. This we have angles. This is 45 degree and this is 25 degree. So 45 degree and 25 degree angles also present in this part. The left bronchus makes an angle of 45 degree with the trachea, and the left is making a 25 degree angle. So right bronchus, it is shorter. You can see the right bronchus is shorter. It is wider, and in line with the trachea, is making a little bit less angle. So it is in line with the trachea. It's like if you will draw a line here, then which is nearer, which is in line with the trachea, we can say the right bronchus. And thus the right bronchus, it is very prone to infections. Like if there is a foreign particle that is invading, it has more chances to go into right bronchus. So your right lung is more prone to the infections. You can write over here that it is shorter, wider, and in line with the trachea. Okay, so you can write, if I haven't written, so infections can easily reach right lung, and thus the right lung is more prone to infections. Right lung is more prone to infections. That's all. And talking about the hilum of the lung, this is the hilum of the lung. This is the hilum, and this is the pulmonary ligament. So this is the hilum, the pulmonary ligament. This combine to form a root of the lung. So you have to just practice drawing this roots of the lung. It's very easy. Right root and the left root. So talking about the right root, what it has in an anterior relation is the arch of Azygos vein will be there. Arch of Azygos vein is present in the roof, and we have inside this right root, we have the eparterial bronchus, and we have the hyparterial bronchus, and the hyparterial bronchus. Your pulmonary artery and two pulmonary veins are there, and the pulmonary ligament, of course. And in the left root, we have what we have. You have the arch of aorta and present in the superiorly. Arch of aorta is present bit superiorly, like not superiorly. You can just say that is present above the root of the lung, of your left lung. And this is again the root. This pulmonary ligament is there, and your pulmonary artery is there. And the left principal bronchus is there. And pulmonary veins are there. So we told that the right bronchus, it divides first, then it goes into lungs. Right bronchus divides first. So right bronchus is mainly dividing into eparterial and hyparterial bronchus, and then it is reaching the lung. So two bronchus can be seen in the root. But the left bronchus, it is even not divided now. It's not divided now. So you can see the whole left principal bronchi in the principal bronchus in the left root. Let's draw the mediastinal surface of the right lung. So if we have the mediastinal surface, this is the mediastinal surface of the right lung. That is what we have done is we are looking at the surface that is facing the viscera, the surface that is facing our facing the mediastinum. It's called the mediastinal surface. Let me show you in a diagram. Yes, this one. You see, this is the mediastinal surface. So we are seeing from this side, we are seeing from this side. So what we'll observe is that mediastinal surface of right lung. So what are the relations and all? So if you draw like this make a shape like this. First of all, what I am saying for your prof exams is you can make a shape like this, and then make the root of the lung. You know what are the contents that are present in the right root. So right root has epiatrial, hypatrial bronchi, your pulmonary artery, then two pulmonary veins are there, pulmonary ligament is extending like this, and then what will have, you have the impression for your superior vena cava. Here is the impression for your superior vena cava that is present. Here is the impression for your superior vena cava. You have to draw this. Then there is the impression for your inferior vena cava as well. Here impression for inferior vena cava is there. Your right atrium is making an impression here. Right atrium, impression for right atrium is there. Here you have the impression for your right phrenic nerve. We told about the arch of Azygos vein, which will be seen here. Arch of Azygos vein. Then the trachea will be present in the upper part. Trachea is present, and another nerve which is right vagus nerve will be present like this. Impression for your right vagus nerve. And below the inside to the root of the lung, you have your esophagus that is lying posterior to the root. So esophagus is lying posteriorly. This is the right brachiocephalic vein, which is also that forming present. Done. This is a mediastinal surface of right lung. Please do practice this diagram. Let's discuss the mediastinal surface of the left lung. So talking about the mediastinal surface of the left lung, you can see the mediastinal surface. Just pay attention that the left lung has a cardiac notch present. This is the cardiac notch that is present, and this is the whole left lung. Talking about this, we have the root of the left lung, which contains a left principal bronchi, and two pulmonary veins are there, and the pulmonary artery is there as well. Then what structures we have here is that we have the arch of aorta, left subclavian, the left common carotid, that is your aorta is dividing into this three branch. This one. So basically what's happening is that this arch of aorta will be present like this. It's dividing into left common carotid. Like arch of aorta is you can just compare this as the arch of aorta. Left subclavian, the left common carotid are present like this, and the arch of aorta will further give branches. And basically this whole diagram, left subclavian is there, left common carotid is there, the arch of aorta is there. This whole part is present in the mediastinal surface of your left lung. What extra things we have is the impression for the left ventricle. Here we had the impression for the right atrium, and here we have the impression for the left ventricle. Here's the cardiac notch that is present. Esophagus must be lying posterior to this, which is not very well seen in this diagram. Then what we have, your right vagus nerve must be present in this, near to the left common carotid artery. Your left vagus nerve is impression is there. The right vagus nerve, we were told, that is present in line with the trachea, Then we have the left recurrent laryngeal nerve, which will be coming from the superior part, and the thoracic duct is present. This is all about your mediastinal surface of the left lung. Let's move on to the lobes of the lungs. What are the lobes of the lungs? So right lung and the left lung. So right lung has 3 lobes and the left lung has 2 lobes. Right lung has 3 lobes, left lung has 2 lobes. Talking about the lobes, we have the superior lobe, medial lobe, and the inferior lobe. And in the left lung we have superior lobe and the inferior lobe. What are the fissures? This is called as the horizontal fissure, which is separating your superior lobe and the middle lobe. And the middle lobe and inferior lobe are separated by both are separated by your right oblique fissure. This is a right oblique fissure which is separating your middle lobe and your inferior lobe. And then we have the left oblique fissure, which is separating the superior lobe and the inferior lobe in the left lung. Let's talk about the bronchial arteries. Bronchial artery supplies the tracheobronchial tree and supplies till the respiratory bronchiole. So we have this many generations of these things are present. Like your trachea is zeroth generation. Then it forms the principal bronchus. Trachea comes and forms the principal bronchus, which is the first generation. And this lobar bronchus, each lobe has one bronchi, These are the lobar branches, that is the second generation. and they form segmental bronchi, which are the third to fourth generation. Then subsegmental bronchus, that is the 5th to 11th generation, subsegmental, and the bronchioles are present. And then after 5th to 11th, we come here and we see that is a formation of your bronchiole, that is your 12th to 15th generation. After that we have the terminal bronchiole, that is the 16th generation. Then respiratory bronchiole, that is the 17th to 19th generation. Alveolar sac, that is the 23rd generation, the alveoli, which is also of your 23rd generation. So we have about 23 generations of divisions here, 23 generations. Talking about the bronchial artery is the right bronchial artery and the left bronchial artery. Right bronchial artery 1 in number, left bronchial artery is 2 in number. Right bronchial artery is a branch of your right third posterior intercostal artery, and left bronchial artery is the branch of your descending aorta. Let's talk about the bronchopulmonary segments. This BPS, part of lung aerated by tertiary bronchus or the segmental bronchus. The third generation bronchus. It told the segmental bronchus are third to fourth. So it is mentioning the third generation bronchus. This is aerated, the part of lung that is aerated by this third generation bronchus. These are called as the bronchopulmonary segments, BPS, bronchopulmonary segments. What is the shape? We have pyramidal shape, apex is towards the hilum, and it is principal for your postural drainage. In chest physiotherapy, the apex is towards hilum and it is forming the principal for your postural drainage. These bronchopulmonary segments are separated by a visceral pleura. These are surgically resectable, like it can be removed. Any segment can be removed without disturbing another segment, for example, you will say many bronchopulmonary segments, like you have carcinoma in this segment, this posterior segment, posterior segment of the superior lobe has carcinoma. So you can remove this posterior segment without disturbing any other segments like anterior or apical segment. So you can just surgically dissect this segment, just cut this segment out. Okay. Talking about the pulmonary artery, it is intersegmental. We'll talk about this. So let's say we have 1, 2 and 3, the bronchopulmonary segments are there. So one tertiary bronchiole that is coming here and supplying this, one tertiary bronchiole that is supplying like this, and then we have the bronchial artery which is present in line with the tertiary bronchiole, and one pulmonary artery is present. So pulmonary artery is intersegmental. And then what we have here, pulmonary veins that is present in admission. This is a pulmonary veins which is going between the segments. Let's talk about the bronchopulmonary segments. What are the segments present? So right lung and left lung. Right lung has 10 segments, left lung has 9 segments. Most appropriate is 9, but you can also just write 10 segments. Okay, because the medial basal segment is not usually present, usually absent, and it's the right apical basal segment is the most dependent segment in the supine position. We'll talk about this in erect. The right posterior basal, right apical basal is the most dependent in the supine position. Right posterior basal is the most dependent in the erect position. We'll talk about this. Right lung, it has first upper lobe, middle lobe, lower lobe, 3 lobes we told. Upper lobe has APA segments, APA segments, apical, posterior, anterior. Apical segment is the least vascular segment. So there is increased TB chances in the apical segment. Okay, apical segment of the upper lobe. Okay. Talking about this middle lobe has LM segment, that's the lateral and the medial. Lower lobe has APA LM segment, APA LM, just remember APA LM. So we had APA LM, okay, upper lobe APA, then we had LM, and lower lobe APA LM, combinedly APA LM. Okay, so this A is the apical basal segment, P is the posterior basal segment, A is the apical basal, which is the most dependent part in a supine position, and the posterior basal segment is the most dependent part in the erect position. So what happens is that in supine position, like a bedridden patients, mostly suffer from aspiration pneumonia. Okay, they mostly suffer from their aspiration pneumonia because they have a fluid accumulation in the right apical basal segment. P is for the posterior basal, A is for the anterior basal, L is for the lateral basal, M is for the medial basal. Understood? Let's discuss the left lung. Left lung has upper lobe has upper C segment, upper C, and the lower lobe as usual it is APALM. So upper C segment, just remember apical, P is for posterior, A is for anterior, S is for superior, I is for interior. This superior segment and the interior segment combinedly are called as a lingular segment. This lower lobe has APALM segments. APALM means apical basal, A is for apical basal, P is for posterior basal, again A is for anterior basal, L is for lateral basal, M is for medial basal. So apical basal, posterior basal, anterior basal, lateral basal, and then medial basal. This medial basal segment, this is usually absent to allow space for the heart. This is usually absent. So we can say we have 9 segments. Understood? Lung diseases. There are many lung diseases like your asthma, lung cancers are there, blocked lung disease, pulmonary embolism, that is a moving thrombus is called emboli. So there is blockage is there. And collapse of entire lung, that is a pneumothorax or atelectasis. Atelectasis, the collapsing of the alveolar walls. Your COPD, chronic obstructive pulmonary disease, your lung infection like your pneumonia, abnormal buildup of lungs, that is a pulmonary edema is there, and swelling and inflammation of the main passages, that is a bronchitis. Understood? This is the patient of a viral pneumonia, how the ECG looks like. This is a normal patient. And for bacterial pneumonia, we can have this type of plagues which are formed. This cavity, this thoracic cavity, that becomes a bit opaque in nature. And viral pneumonia, we can have this it is separated. The things as the opacity is divided. It's more spreaded. And COVID-19 pneumonia is a severe kind of pneumonia. You can see how much opacity has been developed here. These are all your things. Cardiomegaly, you can see the heart has become big. Effusion, that is a fluid buildup here, and a mass is there. Here you can see the mass. A nodule is there. Here you can see the nodule. This can see a pneumonia patient and a pneumothorax in which fluid accumulation is there in this part. Fluid accumulation. Atelectasis in the lung walls are collapsed. Infiltration by fibrous tissues or so. Let's discuss the nerve supply of the pleura. All parietal layers develop from the somatopleuric lateral plate mesoderm. Understood? They develop from the somatopleuric lateral plate mesoderm. All the visceral layers develop from splanchnopleural lateral plate mesoderm. The parietal pleura is from the somatopleuric and visceral pleura is from the splanchnopleural. Talking about the parietal pleura, how is it supplied? So nerve supply is a phrenic nerve. So we have this costal pleura, outer supply of the diaphragmatic pleura. So what happens is that this costal pleura and the outer surface of the diaphragmatic pleura, costal pleura, the outer surface of the diaphragmatic pleura, these are supplied mainly by the intercostal nerves. But the phrenic nerve supplies this pleura, the part of your costal pleura, okay, and the mediastinal pleura. This is the mediastinal pleura and the part of costal pleura, and your inner part, this is the inner part of your diaphragmatic pleura. This three mediastinal pleura, mediastinal pleura, inner part of your diaphragmatic pleura is supplied by phrenic nerve. Understood? Visceral pleura is supplied by the ANS. It is under autonomic control, T2 to T5 segments, and it is insensitive to your pain. So this is all about your pleura. Blood supply of the pleura. Parietal pleura is supplied by your internal thoracic artery, your musculophrenic artery, and the intercostal arteries. The visceral pleura is supplied by your pulmonary artery and the bronchial artery. Venous drainage, internal thoracic vein and the azygos vein. What are the clinicals? Very important clinicals are there in the lungs. Just be 2-3 minutes. Lung of a dead stillborn infant will sink due to absence of air, and the lung of a live born infant will float in the air. So it is a medical legal significance. In stillbirths, you can check from the lung if it is it is sinking or it is not, it's floating. Okay, so lung of a dead stillborn infant is like firm to touch and doesn't crepitate when handled. And the tubercular lesions, talking about tubercular lesions, this present are mainly in the apical regions of lung. Tubercular lesions mostly lodged in the apical region of the lungs. A question from NEET PG 2020. In neonatal respiratory distress syndrome, which is deficit secretion of which cells? Your type 2 pneumocyte cells. Understood? We secrete your lecithin. These are your type 1 and type 1 cells. Between them, we have type 2 cells are present like this. Type 2 pneumocytes, these are secreting a lecithin. Lecithin is a dipalmitoyl lecithin is the most common form. Is a called as a phosphatidylcholine, that is a lecithin. Phosphatidylcholine is a lecithin. Understood? You have read a lot about lecithin in your biochemistry, like your LS ratio. LS ratio is used to check the lung maturity. LS ratio, normal LS ratio is 2:1. If it is less than 2:1, then the lungs are not said to be mature. This is a LS ratio, and many things are. LS ratio means a lecithin sphingomyelin ratio. Understood? So this completes your lung. Let's move on to the next concept. So let's talk about the thoracic duct. Thoracic duct, it is the largest lymphatic duct that is present in body. It drains lymph from this whole part of the body. It drains lymph from the whole part of this body. Okay. So you have the arrangement of this thoracic duct present over here. Let's discuss the thoracic duct. It from L2 level. The L2 level, it goes to C7 to L2. Just can you imagine how huge it is? And here at the C7 level, we have our internal jugular vein in the left subclavian vein. It drains into the junction between the internal jugular vein and the left internal jugular vein and the left subclavian vein. Understood? So it drains into its junction. Talking about this, this drains into this. So how it is coming? That from the cisterna chyli. Okay, like it is going from here, going down. It is parallel to the azygos vein and the aortic. This is the aorta. This is going like this and is like ending in the cisterna chyli that is present in the L2 level. And at the T12 level, you have the aortic opening via which it is coming down. Understood? So then what we have, you can see the relations of it. Like a left subclavian vein is there, left internal jugular vein is there, draining into the junction between both. Here you can trace the thoracic duct like this. So esophagus is forming its anterior relation. Esophagus is the anterior relation. Aorta is the left relation. You can see the left relation is the aorta. Here aorta is present. Then vertebrae, T5 vertebrae. Your T5 vertebrae, you can say vertebrae. Your vertebrae are the posterior relations, and the right azygos vein is the right relation. Very easy. Aorta left relation, esophagus anterior relation, posterior relation is the vertebra, and the right relation is the azygos vein. That completes thoracic duct. Just a little bit to discuss that. So let's move on to the next. So guys, let's talk about the esophagus. Esophagus is a pipe which is 25 cm long. It moves food from the pharynx down to the stomach, and the food movements on the food is called the bolus, and it is not dependent on the gravity. Like if you do that yoga standing on your like hands, standing on your hands and legs are up, that in that time also you can digest your food. Like bolus is not, the movement is not dependent on the gravity. It is dependent on the movements of the esophagus, the peristaltic movements. It is dependent on the peristalsis, the rhythmic contraction of the smooth muscle. And then we have the lower esophageal sphincter present here, LES, lower esophageal sphincter. If this is not working well, there is any disorder, there is any mutation or whatever it is, if there is any problem in the lower esophageal sphincter, there will be backflow of food, and this is called as your heartburn. You have heard people saying that they are having a heartburn. You have heard this term, heartburn. So heartburn is nothing related to your heart. It is due to the failure of a lower esophageal sphincter. If it allows the movement of food, this is also called as GERD. GERD is a gastroesophageal reflux disorder. Understood? So this is called the acid reflux. Normally the epiglottis, additionally the epiglottis prevents food from moving to the trachea, and these are happening. Then esophagus has few parts and few constrictions are there, like your cricopharyngeal constriction, your bronchoaortic constriction, cricopharyngeal constriction, bronchoaortic constriction, your esophagogastric junction. We have different levels at the lengths are there. The lengths are there. We'll discuss in the schematic diagram later. Talking about the esophagus in lower power, this is the histology of the esophagus. It has the mucosa in which epithelium is present. The epithelium that is non-keratinized stratified squamous epithelium is there. Lamina propria and muscularis mucosa, submucosa, and the muscularis propria. What are the relations of the esophagus? What are the relations? Anterior relation is formed by trachea, oblique sinus, and the left atrium. Trachea, oblique sinus, and the left atrium. These are forming anterior relations. And posterior relations are from the thoracic duct, vertebral column, descending aorta, and right posterior intercostal arteries. Okay, right relation is the azygos vein, left relation is the descending thoracic aorta. You can appreciate the relations here. If you can see the trachea is present superiorly, anteriorly. Okay, and the oblique sinus of the heart must be present there, left atrium. And then posteriorly we have the thoracic duct and the descending aorta, thoracic duct, descending aorta, and right posterior intercostal arteries. Right relation is the azygos vein must be present, and left relation is the descending thoracic aorta, Let's talk about the esophageal constriction. So there are 4 constrictions. Your cricopharyngeal constriction, your aortic constriction. Then we will talk about these constrictions. There is diaphragmatic constriction also, and here we have another constriction. So what are the different constrictions? Let's see. The cricopharyngeal constriction, this is present for 15 cm from top, 15 cm from the above the part, that is your upper incisors. We take the upper incisors as the standard, that is it take the upper incisors at the 0 cm. We take it as a 0 cm. You must have observed here also, if you are talking here, upper incisors 0 cm. And then we have the cricopharyngeus muscle. It is given 14 to 16 cm, but you follow the standard part, that is a 15 cm. 14 to 16, that is mean is a 15 cm. This is from Grace, and these numbers are very important. At the level of aortic arch, 22.5 cm, we have another constriction. This constriction like structures you can see here like this, and this is called as a broncho-aortic constriction. This constriction is called as a, you can write, broncho-aortic constriction. Another constriction is that this one at the length is 27.5 cm. This is called as your esophagogastric constriction. Okay, this is your esophagogastric constriction. At this level, this one is called as a esophagogastric constriction. Then afterwards we have a diaphragmatic opening and the diaphragmatic constriction at the T10 level, and the length is 37.5 cm. So it is about 10 cm in length. This is about 10, understood, and this is about 5, and this you can calculate from using subtraction. Blood supply. What is the blood supply? So we have cervical part, thoracic part, and the abdominal part. So cervical part is supplied to the inferior thyroid artery. The venous drain is the inferior thyroid vein, which drains into the brachiocephalic vein later. Thoracic part is supplied to the descending thoracic aorta, and venous drain is the azygos and hemiazygos vein. Abdominal part is supplied to the esophageal branch of left gastric artery. Left gastric artery has had esophageal branch which was going up, and then it was the left gastric artery was going like this in the lesser curvature of stomach, and it was giving some esophageal branches, remember, yes, and the left gastric vein is the venous drainage. Let's talk about the nerve supply. You can take the screenshot of this picture if you want to understand from this picture, but it is a bit complex to understand from this picture. Let me show you in the schematic diagram. It is very easy. So parasympathetic is secretomotor for your esophagus, and sympathetic pathway is a vasomotor for your esophagus. So we have this right vagus nerve, this is a left vagus nerve, and the superior cervical ganglion, middle cervical ganglion, inferior cervical ganglion, T1 to T7 levels. So sympathetic supply is being given by the MCG, that is the middle cervical ganglion, that is also innervating the upper region, the upper part of the esophagus, and this is there is a esophageal plexus, which is sympathetically it is contributed by the T1 to T7 segments, and from parasympathetic supplies, the right vagus nerve and the left vagus nerve are also contributing to this esophageal plexus. So generally you can say nerve supply is via this esophageal plexus. This upper part is also supplied by the recurrent laryngeal nerve from both of the vagus nerves. Recurrent laryngeal nerve from both of the vagus nerves. You can see some things here, but here it is a bit complex, messed up. So you can just remember this diagram. Understood? You can take a screenshot. Yes. So let's finish the esophagus and move ahead in our discussion. Let's discuss the phrenic nerve. Phrenic nerve is a part of your supplying the diaphragm. So basically phrenic nerve is supplying a diaphragm, and how it is moving, how it is going, let me discuss with you. So we have the phrenic nerve here. You can trace in this open section, you can trace this phrenic nerve. It is also giving a branch to your fibrous pericardium. Okay, the sensory branch to fibrous pericardium, and phrenic nerve is passing like this and separating into 4 other branches and all, and piercing this muscle to go ahead. This is your right phrenic nerve, and this is your left phrenic nerve, which is like moving here. So we have the phrenic nerves in both sides of the heart. This phrenic nerve passes behind the ITA. Will root value of the phrenic nerve is C3, C4, C5. Never forget the root value. Forget everything, but never forget the root values of the nerves. So we are discussing a phrenic nerve is the main nerve of your diaphragm, and phrenic term means only diaphragm, related to diaphragm. Root value is a C3, C4 and your C5. Understood? Then we have your left phrenic nerve is longer than the right phrenic nerve. This is a fact to remember. Root value C3, C4, C5. Let's discuss the course in this section, in this schematic section, because it becomes very difficult to discuss this things in your real-time section. So schematic sections all help in every aspect. Okay, so you have this scalenus anterior muscle. This is the scalenus anterior muscle, and you have the subclavian artery and the vessels below which the phrenic nerve is passing. Between the scalenus anterior, it is descending in front of your scalenus anterior muscles, but passing between the subclavian arteries and the veins. It is passing between the subclavian arteries and the veins. These are passing like this, subclavian arteries and the veins. Between the subclavian arteries and veins, these are your phrenic nerves which are coming, and this is your phrenic nerve of the right, that is a right phrenic nerve, just going besides this heart. Okay, and your left phrenic nerve is coming like this and going down. Understood? And supplying the diaphragm. So let me state the exact course in the flowchart manner. C3 to C5 it starts and descends anterior to, as I told, descends anterior to your scalenus anterior muscle. It descends anterior to the scalenus anterior muscle. It passes between the subclavian artery and vein. It is seen behind the internal thoracic artery. It's seen behind the internal thoracic artery. Here you can see internal thoracic artery. This is the internal thoracic artery, and behind it your phrenic nerve is passing. So it is seen behind the internal thoracic artery. It is seen with pericardiophrenic artery. It is seen also with the pericardiophrenic artery. This pericardiophrenic artery is probably lying parallel to the phrenic nerve, the course of the phrenic nerve, and with pericardiophrenic artery, then it runs adherent to the fibrous pericardium. It runs combinedly with the fibrous pericardium, divides into right phrenic nerve and the left phrenic nerve. This right phrenic nerve gets out by the vena cava opening. This left phrenic nerve goes out by piercing the left dome of the diaphragm. Okay, right phrenic nerve is the component of the vena cava opening. Remember, the left phrenic nerve, it pierces the left dome of the diaphragm and supplies the diaphragm from its inner surface. Very important. It supplies the diaphragm from its inner surface. You can see superior surface is not supplying. It's supplying the diaphragm from the inner surfaces. The motor supply of the diaphragm is the diaphragm. Sensory supply of fibrous pericardium. It gives a motor supply to the diaphragm, and the sensory supply is given to your mediastinal pleura, also central part of diaphragm, diaphragmatic pleura, and your fibrous pericardium. So there are 3 sensory branches to the mediastinal pleura and the central part of diaphragmatic pleura. One branch you can consider. We discussed this in your pleura topic, and another branch is to your fibrous pericardium. Clinical So phrenic nerve damage, this phrenic nerve damage is paralyzed. Half of the diaphragm will relax and pushed up into the thorax if that is the phrenic nerve damage. So half of the diaphragm, paralyzed half, will be relaxed and pushed up into the thorax, and the lower lobe of lungs of that side will collapse. The lower lung will be collapsing. Then let's talk about the accessory phreniculum. This is present in 1/3 of people, 1/3 of population. Accessory phreniculum is also present in the 1/3 of the population. Arises from the nerve to subclavius. Do you remember the nerve to subclavius? We had a brachial plexus like this, the C5 segment, the C6 segment, the C7, and then we had C8 and T1. Understood? And these were the roots. So from the upper trunk, middle trunk, and the lower trunk was there. From the upper trunk there was arising which nerve? The suprascapular nerve, that is, and another one, sorry, subscapular nerve, and another one is your nerve to subclavius. Yes, do you remember? Yes. So nerve to subclavius is arising from a brachial plexus, that is from C5 root, and this accessory phreniculum, this arises from the nerve to subclavius. It then leaves the nerve to subclavius to join the main phrenic nerve. So we have accessory phreniculum. This is APN, accessory represented by APN. Okay, and this accessory phrenic nerve is basically, this is connecting. This is like arising from the C5 segment and is connecting to the main phrenic nerve. This is the main phrenic nerve. So it is arising from the C5 segment. This comes here like this, and joins with the main phrenic nerve. This is the main phrenic nerve. This is your main phrenic nerve. Okay, so that's all about phrenic nerve. Let's move on to the next. Let's talk about a typical vertebrae. So a typical vertebrae, what are the things that are present? So we have vertebral foramen, we have a spinous process here, we have two transverse processes and all, and we have a pedicel. This part is called the pedicel. This is the body of the vertebrae. So basically what we have is this is the pedicel of the vertebrae, sorry, this is the body of the vertebrae, and these two parts are called as the pedicel. This is the vertebral foramen, and this is a spinous process, this present, and transverse process, and another transverse process. Okay, so these are present in your typical vertebrae. Talking about let's discuss in more detail. So this is a typical thoracic vertebrae. So what we have a body, and we have superior costal facet. Are there. We have costal facets on the transverse processes. That is called the transverse costal facet. So a typical thoracic vertebrae has your superior costal facet and your transverse costal facets. So this is a superior articular facet of the costal facet. This is a transverse costal facet. Understood? This is a superior costal facet, and these are your transverse costal facets on the transverse process. Okay, and rib is attached to these two locations. We have in your vertebrae, we have a upper demifacet. Is the half facet, upper demifacet, and the lower demifacet. The lower demifacet of the first vertebrae and the upper demifacet of the lower vertebrae is basically attaching to the rib. Okay, so we have a demifacet and a demifacet. Two demifacets are there in the typical thoracic vertebrae, and a transverse facet is present in the transverse process. And just consider another vertebrae will have like this, a demifacet. So rib is attached to this both demifacets. Understood? Let's discuss the atypical vertebrae. So T1, first of all, is the T1, that is, it has an upper complete facet. Okay, demifacet is not there, a complete facet is there. Let's discuss the T9. T9 is why it is abnormal, it's atypical, because the lower demifacet is absent. Lower one is absent in T9. In T10, what happened? This upper one is complete and lower one is absent. What has happened in T1, T11? We don't have any transverse facet. Or any no lower demifacet. We have a upper complete facet. T12, the upper facet is shifted towards the pedicel, and there is no transverse facet. So these are atypical ribs, atypical vertebrae, which are 5 in numbers. That completes the vertebrae. Let's move on to the next. So let's now come to the mediastinum. So you know a great deal about the mediastinum, and what you can see is that in a superior mediastinum, you can see what are the things that are present. The arch of aorta is present over here. The descending arch of aorta is going into your posterior mediastinum, and this pulmonary trunk is present here in the superior mediastinum. Superior vena cava is going down like this, so it is also present in the superior mediastinum. The branches of the arch of aorta is lying in this manner. We have the esophagus that is extending from the superior mediastinum, so the content of the superior mediastinum also, and is also a content of your posterior mediastinum. This thoracic duct also is lying in superior mediastinum as well as extending in the posterior mediastinum. So we have the superior mediastinum. This purple part is the superior mediastinum, and we have the anterior, medial, and the posterior, inferior mediastinums. What are the boundaries of the superior mediastinum? Anterior boundary is the manubrium of the sternum. You can note well. This is the manubrium, and it's forming the anterior boundary. Is forming the anterior boundary of this superior mediastinum. And the posterior boundary, your T1 to T4 vertebrae is the posterior boundary. So you can just see posterior boundary T1 to T4 vertebrae. Roof is from the suprapleural membrane. We talked about this. This is the inlet. This is the inlet. Okay, this is the inlet of the thorax. We call it inlet of thorax. And this inlet of thorax is made up of suprapleural membrane. Suprapleural membrane, and the suprapleural membrane is also called as the Sibson's fascia. Your Sibson's fascia. Understood? Talking about the floor is the imaginary line that is connecting the sternal angle to the lower border of T4. You can see imaginary line which is connecting the sternal angle to the lower border of T4 is forming the base, is forming the floor of your superior mediastinum. So that's about your superior mediastinum. You can write the contents, and each side it is surrounded by mediastinal pleura. Each side is surrounded by the mediastinal pleura. You can write the contents easily. Many contents are there. Esophagus, and this all you can write. Talking the posterior mediastinum, above is your sternal angle. So it is posterior mediastinum. This is the posterior mediastinum. This is the posterior mediastinum is this part, and surrounded by this sternal angle in the anterior part. Sternal angle in the anterior part. In the above part, below is you have a diaphragm. Below you have your diaphragm. Below you have your diaphragm. What is the anterior part? Anterior part is the middle mediastinum. Anterior part will be the posterior wall of your fibrous pericardium. Posteriorly we have the T5 to T12 vertebrae. We have the T5 to T12 vertebrae, which is the posterior boundary, and side is surrounded by pleura again. Let's talk about this thoracic sympathetic chain. So talking about the thoracic sympathetic chain, we'll see the formation of your ganglions, okay, and how they are supplying, which ganglions they are forming and which plexuses they are forming. So first what happens, this thoracic sympathetic chain, okay, we have this arrangement. We know this arrangement: superior cervical ganglion up to T12 level, and superior cervical ganglion up to T12 level again. Okay, so what we have is that this red nerve, just consider this red nerve from T5, T6, T7, T8, and T9. It is taking origin. This is called as the greatest splanchnic nerve. From T10 and T11 we have our lesser splanchnic nerves originating, and from T12 we have our least splanchnic nerve. This is least splanchnic nerve. This is the lesser splanchnic nerve, and this one, this is your lesser, this is your greatest splanchnic nerve. Okay, so L is for lateral, so L for limb, and M is for medial, M for midline. We'll talk what is we are talking about. So you can see the dorsal root, it is sensory, the ventral root is motor. So this is a basic discussion of your spinal cord and all. This is the dorsal root, and this is the ventral, the dorsal ramus and the ventral ramus. There's the dorsal root ganglion present in the dorsal ramus. Okay, and it is now converging and forming another ramus, which is this one is a gray ramus communicans, and this one is a white ramus communicans. Okay, so we have the lateral horn. This is a lateral horn, this is a ventral horn, and this part is a dorsal horn. Then what we can say that from the intermediolateral nucleus, this preganglionic sympathetic neurons, they arise, and this relay into this ganglion, and from here the postganglion sympathetic neurons can go away. So this white ramus communicans, it is generally containing a preganglionic sympathetic neuron, and the gray ramus is containing a postganglionic sympathetic neuron. What is the meaning of a splanchnic nerves is that it arises from the SC, that is your superior cervical ganglion. This is SC, and here you have the diaphragm present. There's the diaphragm present, and sorry, SC is the spinal cord, right? What I'm saying, I'm sleepy perhaps. SC is the spinal cord, and from the spinal cord this is arising, preganglionic fibers are arising and relaying in the relaying in the sympathetic chain of the thorax, that is thoracic sympathetic chain relaying, and the postganglionic fibers, these are going towards the heart. And here we have the preganglionic sympathetic nerve, like this is not relaying, and it is directly passing the ganglion and coming, it's piercing the diaphragm and coming, and giving the postganglion sympathetic neurons to the stomach. So this type of nerves are called as splanchnic nerves. Okay. What are the branches of the thoracic sympathetic chain? We haven't shown the branches here. In fact, we have shown the branches. You have your greater splanchnic, lesser splanchnic, least splanchnic nerves, which I have shown in this diagram. We have shown the branches. Just remember that the inferior cervical ganglion and the T1, this form is stellate ganglion. And here also we have the stellate ganglion. So let's talk about the branches of the thoracic sympathetic chain. Talk about the medial branches. Let's talk the medial branches from T1 to T5 ganglion, the postganglionic nerves, which is contributing to the cardiac plexus, is contributing to esophageal plexus, to the aortic plexus, to the pulmonary plexus. Okay, so there are 4 plexuses that are contributed by this medial branches. What are the medial branches? This one are the medial branches. Okay. And this T5 to T12 ganglion, the preganglion sympathetic nerve are there, which pierce the crust of the diaphragm and form ganglions in the abdomen. Okay. What are the types of this form? Those who have the greatest splanchnic nerves, or the lesser splanchnic nerves, and the least splanchnic nerves, or renal nerve. So greatest splanchnic nerve, this arise from the 5 to 9th ganglion. You can see. So 5 to 9, these are giving rise to greatest splanchnic nerves. 5 to 9, these are giving you greatest splanchnic nerves. You can see well and observe. And this relay in aorticorenal and the suprarenal gland, aorticorenal ganglion and the suprarenal gland. And lesser splanchnic nerve, which is arising in the 10th to 11th ganglion. You can observe here 10, 11, T10, T11. These are giving rise to lesser splanchnic nerve. And this lesser splanchnic nerve, these are relaying in the celiac ganglion, okay. And on the least splanchnic nerves, which are arising from the 12th, these are called the renal nerve, and these are forming a renal plexus, okay. Talking about the lateral branches, these are pilomotor and vasomotor, and supply the sweat gland also. Pilomotor, vasomotor, and supply the sweat glands. They supply the limbs and the body walls. So I haven't shown the lateral branches in this diagram. We have only shown the median branches, okay. So that's all about the mediastinum. That's all about the thoracic sympathetic chain. That's all about your thorax. So I hope you enjoyed the lecture. Of course, thorax is not a big deal, and it's a very sweet chapter, and it's a very concise chapter. We'll talk about the embryology of thorax. This embryology of thorax in separate video. Embryology of your thorax, that is the embryology of your arterial septum, your septal development. We'll talk about your right atrium development, your right ventricle development, ventricular development, and all, heart tube and all. So we'll talk about this in the next video, as there are demands to shorten the videos. Not in the next video, in some other video. Next video we're gonna continue our marathon session, and we're gonna we have a big chunk to finish, that is your neuroanatomy. We have done your day one. Your day one was your upper limb, your lower limb, and your genetics. And genetics is just insignificant. Day two I talked about your pelvis. Day 2 was your pelvis day. Day 3 was your abdomen. Day 4 was your thorax. You can easily do this 2 chapters in one day, so you can consider this in day 3. And we'll meet tomorrow. And we'll have the day 5. And as per the day 5 demands, we'll see if we'll start the neuro or your head and neck. But it's gonna be another very amazing lecture, because we have the neuro part to finish off, that is the head and neck, face, and the neuro part. It's a bit complex, but I will try to explain you in the very simplest form. Okay, so I hope you will join the lecture, and that's all in today's lecture. So thank you. And if you like the video, if you loved the lecture, do like, share, and subscribe to my channel more and more, as I keep on taking up this lectures, and in future there will be more lectures of this kind also. Okay, so that's all for today. Thank you and good night.